being more pro-rhythmic, right,
Yeah.
than Levophed. And that's one of the reasons that Levophed is preferred over dopamine in most patients. But you might see a dopamine in a bradycardic hypotensive patient.
Mm-hmm.
Okay. So normally we're starting off with Levo. It has the best outcomes for first-line sepsis, right? I believe that the guidelines, I think that they're clear. They're clear for Levo being first line for sepsis. They're fairly clear, I think, for vaso for second line, right? And sometimes in sepsis, you're vaso deficient. And there's an argument of, or there's a debate of when to start vasopressin. Some people will debate that you started earlier, and these people are like, well, you might have better outcomes. And some people don't see that, so they start it later. This is expensive, but reasons why that you could start this earlier, right, is, obviously, if your patient's requiring quickly titrating it up, you could go ahead and start it earlier. But if your patient's becoming very tacky on this Levo, if I add this vaso, I'm going to get more SVR, right? And I might not have to have such a high dose with the Levo, so the risk of tachyarrhythmias go down, right?
Mm-hmm.
So if I add vaso on earlier, then maybe my tachyarrhythmias will go down. So if you have a patient who becomes tacky on the Levo and they're only at 8, right? It's not that high. But if you could ask the doctor and be like, hey, my patient's tacking away at 150, 160. I'm only on 8 of Levo. Do you want me to add vaso? Right? So then the amount of Levo that you got to give would be lower. Therefore, the beta-1 will be lower, and the risk of tachyarrhythmias would be lower. The other option that you could do is to change it to neo, right? So if I have a patient starting off at 180, right, heart rate, maybe I'm not going to do quote-unquote first-line therapy of Levo since their heart rate is so high. The physician might order a neo, and that might be the thought process behind it. Because if I'm just vasoconstricting alpha-1, I'm doing nothing to the heart, right? Mm-hmm. And in fact, you have these baroreceptor reflexes in your aortic and your carotid and different locations in your body that sense your blood pressure, right? So if I vasoconstrict, your blood pressure goes up, your body senses it, it sends a signal to try to fix that elevation, and it will actually reflex into a bradycardia, okay? The opposite is true if you give a direct vasodilator that does not affect the heart, like hydralazine. You might open this, blood pressure might drop, your body tries to fix it, right, and goes tachycardia. Like beta blockers and certain calcium channel blockers, you might not see certain things because it controls maybe both or controlling the heart rate. Mm-hmm. So, Levo, neo, in that case, you might see a reflex brady, so it might help the heart rate indirectly. Does that make sense? Mm-hmm. Okay. And epi is very powerful. It's got the beta-1 and the alpha-1. The reason it's not used usually as first-line treatment is due to that beta-1 being so high. It does have more of a propensity to cause tachyarrhythmias than Levo. Mm-hmm. I know that there are certain articles that debate, whether or not it should be used first line or not. But that would be why we don't always use it first line. Check. Ang-2 is the most expensive. It does have an indication for sepsis. It's placed in therapy, so they're clear about first line. They're clear-ish, I think, about second line being vaso. Third line, from my experience of reading some of these articles, is like they don't know. You know what I mean? Mm-hmm. So first line Levo, second line usually vaso, third line whatever your favorite is. Mm-hmm. And some of these thoughts might go into it, but Ang-2 would be like a third line pressor, or it could be maybe a second line if you're already maxed on epi. So epi is very powerful. If you're already maxed on epi, you can consider the Ang-2 as your second line. But Ang-2 is definitely not first line. Mm. And it's only like a second line and Wellstar if you're maxed on epi. And it does have an indication for sepsis, and it is often used outside that indication as well. Okay. And It's dosed a little different where it can have like a max dose. I don't know if Wellstar has this all the way up to 80 for a short period of time, for a couple hours, and then go down to 40. I think we just have 0 to 40. I'd have to check. But it is dosed a little bit different like that. It has a weird clot risk that they saw was super low. No one knows why, as far as I know. So we try to make sure that the patient's on some DVT prophylaxis. I believe that we ordered this for bed 6 just now, who's bleeding out. And you know, some of the thought that went into that was, maybe you don't help him clot, because we're trying to give him some things, a little bit, to make him not bleed. Check. And these are not really pressors, these are onotropes. But I just included those because we can talk about beta 1, beta 2, and heart rate. Check. So, any questions so far? Opening up for some questions.
Isn't dopamine usually the one that's, I get dopamine and dobutamine mixed up.
Yes.
One of them specifically you'll give for heart failure or cardiogenic shock patients.
You have to be careful in giving some of these.
Because one of them you have to make sure that they have enough fluid in their body before.
All of these, like in sepsis and stuff,
Yeah.
all of these you need to make sure that you got enough volume for them to work properly. Especially like the Neo, like the Alpha one, they don't have any of the heart rate. But like in heart failure, you'll see these two, right? Because their EF is normally really, really bad, and we're trying to boost it, right?
Like our cath lab patients and stuff.
Yeah.
You'll see a fair amount of the cardiologists place the patients on dobutamine if their EF is what normally is it less than.
I mean, they'll be going by like SVO2.
Yeah.
So, those people, they probably have EF way below 40. The challenge is, with heart failure, you don't want to put a lot of strain on the heart, right? With using these, although sometimes you have to. This is preferred, but the side effect could be lowering your blood pressure, right? You got one that's renally dosed and one that's not. They can both increase, cardiac output. They might have a side effect of decreased blood pressure, and they could also, like, if you increase force of contraction and increase your heart rate, you need to not have some ischemia going on where you might cause an MI or worsen an MI. But if it's just like an EF or SVO2 or poor perfusion that we need to increase cardiac output, those would be the way to go. But we might have to go here if we don't have good blood pressure, which would have this increased SVR, which is not great for heart failure, but you gotta do what you gotta do. Yeah. So, should we talk about titration?
Yes.
Is that the topic we should talk about?
Yeah.
Okay, so what questions do you have about titration?
When it comes to if there's like multiple pressors, like let's say Levo and Neo, and possibly even Epi. I know Vaso you don't titrate, it's just the standard 0.04.
Or 0.03.
Oh. I
So
don't think I've done that right now.
there's two little buttons whenever you're ordering it, with two standard, like septic shock. When you're using it for a vasopressor, you have 0.03 and 0.04. 0.03 raises the blood pressure, and just like 0.04, but the higher dose of 0.04 has a risk of increased renal injury. So there's some studies that would recommend to do 0.03. We have some physicians who really prefer the 0.03, and then some that doesn't give that study as much weight, and they'll choose the 0.04. Or if your patient's crashing even more, they'll do the 0.04. But yeah, so say you got the Vaso, the Neo, and the Levo.
Which one are you going to titrate? Like, let's say we want to get the patient off of one of the pressors.
Right. So
Do you
normally,
How do you go about it?
say you got a Levo, Vaso, Neo, right? The Neo is probably going to be added on
The third.
the last one, right? And if my goal is to just come off pressors in general on a general septic patient or shock patient, I would just take the neo off, right? Because then I have the recommended first and second. But if I am having like those tachyarrhythmias, then I would want to increase my neo or leave it the same while I decrease the levo. Does that make sense? So preferred would be levo and vaso, but if I can't, then I'll have to leave the neo and go down on the levo. Also, you see neo sometimes peripheral, right? It's just about as risky as levo, but I really hate to see vaso peripherally because it can really cause some issues. So neo I'm okay with, levo that's okay. Try not to have them quad. We don't want quad going peripherally, but vaso I really don't like to see peripherally. Okay, just throwing it in. Anything else?
Now, Bo, so some of our providers have kind of gone back and forth with. So before, we would normally come down on levo to about 10 mics, and they would still be on vaso as well. And then we would normally try to turn the vaso off and then still titrate down on the levofed. But some providers are starting to think as though we should come off the levofed first and then
right. So there's
come off
a couple studies that look at that. And I know in the past, before Epic, we had it set where levofed would come off first and then vaso would come off last. And I'm kind of in that camp